Hi, everybody. My name is Kevin Ressler. I'm the president and CEO of United Way of Lancaster County. And I want to welcome you to this afternoon. I want to welcome you warmly to this conversation. This is an important conversation, and all conversations are important, right? But this one's important because it doesn't just deal with each of us individually. It deals with the whole community and what does it mean to be community with one another? What does it mean to have responsibility to care for one another? This is what our Women in Health panel here. These are women who, that is what they do professionally. They are doing work that cares for the community and thinks about other individuals in ways that maybe beyond just the business case, but thinks broader and more extensively. I want to just let you all know that this is being recorded and we will be able to distribute that. Those who were not able to attend will be able to receive that. It will be posted on our oneunitedlancaster.com website as an article wrap up as well. So I want to take a few moments to say a few things. The first thing I want to say is in my job as the president and CEO of United Way, as well as in my experience in other nonprofits before here, I have learned a thing, and that thing is that I often enter into rooms, digital and physical, that have a large amount of women in the social service sector. And this doesn't surprise me. It doesn't surprise me because I've previously done work in microfinance. And one of the things that we often said was, when we think about microfinance, no matter where it is in the world, you give the money to the mothers, you give the money to the women, to the caregivers for the community. If you give it to the men, they'll spend it, they'll squander it on themselves. If you give it to the women, they do things to develop and to grow the community wealth. Women have been caregivers throughout history, professionally and individually. And so when we thought about who do we begin with a conversation about the wellness of our community, the public health and the initiatives that we want to think about, how do we care for one another, we knew that we needed to begin with women. And what greater time to do that than this month, a month that is set aside to honor women, International Women's Month, and to think about the contributions of women. And so I want to speak specifically about how we got here. About a year ago, COVID hit and our world shut down. And I like to talk about the fact that 9/11 happened when I was in high school. And I remember that in one day, over 3,000 people died and transportation worldwide completely changed. I think about organizational change in this time as an opportunity. And also as a mandate. If you owned a small airport in 2001 and you're doing great in August and all of a sudden September 11 hits, you would have to completely rethink what it is that you do. By October, by November, or no one's going to fly through your airport anymore. At the height of the pandemic, in America alone, 3,000 people were dying every day. How is our world changing? Are we daring enough to recognize that good enough is not good enough and that we need to find ways to move towards great? That means risk and it means creative rethinking. So at United Way, we have for 96 years been driven by thinking about the community work we do from a needs assessment perspective, from taking a look, from being willing to recognize what we were doing yesterday may not be enough for today or tomorrow. And so I began the process of looking for whether or not we could put together a survey on the economic impact, the social impact. And when we first looked at this, I got some quotes. They were expensive, $80,000, $90,000, because we wanted to do it multiple disciplinary. We wanted to make sure that we were not missing the opportunity to ask a variety of rich questions. And as we reached out to different entities, we looked at CARES Act dollars and other things, and it was not something that was funded. And so I spoke to Ramon. And Ramon said, well, the Center for Sustained Engagement with Lancaster has some funding that they can pay for the faculty work. And this can be done in a wide-ranging way. So grateful for the opportunity to partner with them. And every year we use F&M to do a study, one in which we do not help form the questions, but we are willing to be open to hearing where we can improve. And that was the same process we used here. So for United Way, this was a great opportunity to take that pre-existing relationship and not have to actually put any new dollars towards this, but use what was already in our budget. And Franklin and Marshall came alongside and was able to, with their grant partners, bring the significant funding to put this together for our community. Today, you will receive the results of that survey, the public health part. Many of you may have seen in the newspaper a couple months ago the economic impact, the questions about mask wearing, the questions about where people go in the community and their risk factors. That part of the survey is having a second analysis done right now, months later, to see what has changed in our community. And we look forward to further conversations. That's where we're going next, to continue to be driven by data, to think about ways in which we can help to improve the wellness of Lancaster. I'm looking forward to those conversations in the future that bring together other individuals outside of health specifically. And I hope that you'll join us in those conversations as well. Each of you plays a part in this because public health is wider than just medicine. Public health is air quality, the seatbelts you wear, deals with mental health, it deals with all sorts of things that you may not even realize, environmental and the social determinants of health. And so whether you're wearing a mask, getting a vaccination, and I hope you're doing both of those as soon as you can, or in your everyday life, thinking about the importance of pollution and air quality and water quality and the decisions you make, we each have the opportunity to care deeply for one another. I'm going to ask one last thing of you, and that's to join me for just a quick moment as we reflect on the losses of life in the last year, the losses of comfort, the losses of confidence, and all of those struggles that so many of us have had to deal with in a disproportionate way. So please join me in a moment of silence. Thank you. As I often say, we have experienced this together, but we are not all in this at the same levels. Different people have different challenges. Be sensitive as we go and we walk through our paths in our daily lives, knowing that we all have the opportunity to brighten someone's day and make their path easier. Without further ado, I would like to welcome Ramon Escudero. Thank you.
Thank you, Kevin. Good afternoon. I am Ramon Escudero, Director of Franklin and Marshall College Center for Sustained Engagement with Lancaster. I would like to welcome everyone to Lancaster Women in Health Conversation about Public Health, which the F&M College Center for Sustained Engagement with Lancaster, CSOL, is proud to co-host together with United Way of Lancaster County. It is very exciting to see how a collaborative research partnership these two organizations embarked about a year ago to assess the health, social, and economic impacts of COVID-19 in Lancaster County generates this much needed discussion. I'm also thrilled that we can have it within the framework of celebrating International Women's Month. The research collaboration I refer as the starter of this discussion is a multidisciplinary study which covered the fields of economics, government, public health, sociology, epidemiology, and language learning, and has been designed by a team of 5 F&M College faculty in partnership with F&M Center for Opinion Research, and will continue its assessment throughout the next few months. Franklin and Marshall College Center for Sustained Engagement with Lancaster is a hub for generating new avenues of inquiry, initiative, and research collaborations between F&M College and diverse constituencies in Lancaster County. This vision was formulated in response to Lancaster's regional challenges. CSOL, as we like to call it, is funded by a generous grant awarded to F&M College by the Endeavor Foundation. Using models of engaged scholarship, CSOL's research projects and programs regenerate intellectual and social capital essential for a thriving Lancaster that sustains justice, equity, and communal well-being across all sectors. CSOL's governance also reflects and promotes the values of engaged research, undertaken in the spirit of reciprocity, respect, and the cultivation of democratic values. CSEL connects faculty research with pressing regional issues, as the impact of COVID-19 in Lancaster, bringing theory to practice to transform both the institution and the larger community in which we reside. If you would like to learn more about how FNM College professors collaborate with community members towards positive change, please check us out at fnm.edu/CSEWL, which are the acronyms for the Center for Sustained Engagement with Lancaster. Welcome again, everyone, and thanks, Kevin, for the opportunity.
Thank you, Ramon. Thank you very much. My name is Susan Baldridge. I am the Executive Director of the Partnership for Public Health, which is a nonprofit in Lancaster County that deals with public health. I know many of these dynamic women and personally and professionally, and I am just awed with the level of professionalism that I'm seeing today. And I am hoping we have a really deep and rewarding chat about public health in Lancaster County. I think we're going to start with a wonderful presentation from Jen Myers about the survey that Kevin Ressler referenced. And so, Jen, would you like to start?
Sure, let me just get this set up here. Susan, can you just confirm that you can see those slides?
Yes, I can see them.
Okay, perfect. Thanks. Okay, thanks so much for that introduction, and thanks to everyone for attending this forum today. I'm really excited to present the results of our study in this way, and just wanted to give you a little bit of background about myself before I begin. So I'm an assistant professor of public health and government at FNM. I am trained as an economist, and I primarily study the demand for and impacts of various health policy, so particularly environmental health policy. And last summer, some colleagues and I got together to conduct a survey to assess the economic and social impacts of COVID-19 in Lancaster County. That's the study that Kevin and Ramon detailed in their introduction. And at the time, there were lots of national surveys being done, but we really wanted to understand the impacts within our own community. So 4 other researchers from FNM and myself designed this survey and launched it between September and November of 2020. And in addition to understanding the impacts of COVID-19, we were also interested in measuring the demand for a public health department in Lancaster County. So is this something that people want? And if so, how much do they want it? And as an economist, I'm trained in survey research methods to elicit such measures of demand. So in addition to measuring demand for a public health department, we also wanted to see how much of this demand was driven by the current COVID-19 pandemic. So for example, if we found really high demand, was that just linked to the fact that we're currently living in an unprecedented pandemic? So today I'm going to give you an overview of the methodology that we used and our main results from this survey. And before I get into that methodology and results, I want to give you a picture of what our survey sample looked like. So we interviewed over 2,000 respondents in Lancaster County. And because people have to agree to take the survey, the overall sample was not perfectly represented. I'm seeing a question from Kate about how the 2,000 Lancaster County residents were selected. They were selected randomly based on a random sample that the Center for Opinion Research uses. The Center for Opinion Research is located at FNM. So because people have to agree, though, it's not a perfectly representative sample of Lancaster County, and that's pretty common in most surveys. You get some selection into the sample. So to make our analysis reflect a more representative Lancaster County, we conducted what is called post-sample weighting. So essentially, we weighted different groups and individuals in our analysis so that they better matched the demographics of Lancaster County. And we used data from the American Community Survey conducted by the US Census to generate those appropriate weights. And then further, we also analyzed our data by subsamples. So for example, by race and education levels to better understand demand within each subpopulation. So getting into our methods now, we aim to measure how much residents in Lancaster County want a public health department. And we know in survey research that if we just ask people, do you want a public health department, that we're going to get a gross overstatement of demand because there's no cost to them to saying yes. So instead of asking that question, we used a contingent valuation method. And what this method does is it provides some information to the respondents so they understand the potential benefits they're being asked to consider. And then it sets up a hypothetical referendum with an annual cost and asks respondents if they would vote for or against the proposal at that cost. Then contingent valuation surveys include a debriefing section with information about the actual cost because we do not want respondents to confuse the cost presented to them in the survey with the actual cost of a public health department. Importantly, this section comes at the very end, so it has no way of influencing their responses. In our survey, we started with the $50 annual cost to the individual. And if they said yes, they did want a public health department at that cost level, we then asked, well, what about at $100? And then if still yes, then what about at $250? And if they said no, we said, okay, well, what if it costs $25 a year to you? And if they still said no, we asked, okay, what about if it costs $5 for a year? So now I'm going to walk through the exact framing of our questions in the survey. So the part that's highlighted here in green is designed to introduce a public health situation. So the public health situation in this case was COVID-19. And then to set up this hypothetical referendum. So to say, Lancaster County, imagine that there's a referendum that would create a public health department. In the next part of the question, we give examples of benefits that a public health department can provide. So it's important for contingent valuation surveys to both ask respondents to consider the potential costs in the form of annual taxes and the potential benefits. And literature has shown that it is easier for respondents to respond to demand questions if they're given information about a very specific issue. So again, here we focused our attention on COVID-19. And if we didn't couch the question in a specific issue and instead asked about general support for a public health department, research shows that we'd be susceptible to getting an overstatement of demand. And finally, this last part of the question sets up a probabilistic potential benefit. And again, the literature has shown that to avoid overstating demand, surveys should use hypothetical probabilistic benefits. We selected 25% based on other contingent valuation studies in public health and based on conversations with medical professionals as a reasonable benefit that a public health department might offer. And while we feel that this is a reasonable benefit given the literature and our consultations with these medical professionals, it's also important to note that as an economist, we can mathematically scale demand estimates to different probabilistic benefits with some simple modeling assumptions. So after respondents received this information, they were then asked whether they would vote for a referendum to create a public health department if the cost of such a department was $50 more in taxes every year for themselves and everyone else. And there's some important things to note here. First, we made it very clear that they themselves would have to pay this tax. So this is a personal cost to you. We also reminded them about their current budget. So given your current budget, would you vote for or against? And this is really important to do in contingent valuation studies. Asking people to reflect on their own current financial situation reduces the likelihood of overstating demand. Respondents could vote for, against, say they didn't know, weren't sure, refuse the question, or vote to abstain on the referendum. And to contextualize that $50 per year number, if we assume approximately 400,000 tax-paying adults, that tax would fund approximately a $20 million per year public health department, which according to my understanding is a pretty gross overstatement of the actual cost of a public health department in Lancaster County. So hopefully what you can glean from all this is that we selected language, methodology, and costs to generate conservative measures of demand for a public health department. And we did this because we as researchers were interested in learning what true demand was for a public health department. And finally, if a respondent said yes to the $50 annual cost, we repeated the question, with an $100 per year annual cost and then a $250 per year annual cost. And if they said no to the $50 annual cost, we repeated the question with a $25 per year annual cost and then a $5 per year annual cost. And varying these costs in this way allows us to get a full picture of what demand for a public health department would look like. Okay, we also wanted to see how much of demand was related to COVID-19. So we randomized respondents into two groups, or what we call conditions, the lead condition and the COVID-19 condition. So only half of the survey respondents saw all of the text that you just saw, which is the text on the right. The other half of the survey respondents saw parallel text, but with information about lead in Lancaster County, which is the text in blue on the left there. So essentially, we can compare demand estimates between those two conditions to understand the extent to which demand for a public health department is being driven by COVID-19. All right, so if survey methods really bore you, then you can tune back in now because I'm going to get into some of the results from this study. So first, I just want to give you a little bit of information about how to read these graphs. You'll see that each bar has a little line on the top of it. That's called an error bar. And essentially, if those lines overlap, so you can see here that this line falls within this one, and here they overlap a little bit, that means there's not a statistically meaningful difference. So for example, if you look at the $50 hypothetical annual cost, it might look like those in the lead condition have a higher demand than the COVID-19 condition. But because those error bars overlap, that's not actually a statistically meaningful difference. The other thing I would like to note is that the percent willing to pay over here reflects those that voted for the referendum at that cost. So let's take the $5 cost level. 92% of the people in the lead condition voted for the referendum at that cost. However, that does not mean that 8% of people voted against the referendum, because remember, they could vote against, abstain, say they don't know, or refuse the question. So the way that I'm presenting the data here are our most conservative estimates of demand. So what does this graph tell us? Well, we can see at this low cost level of $5 per year that over 90% of respondents voted for a public health department in Lancaster County. And even at the more expensive $50 annual cost level, which again would fund approximately a $20 million public health department, we see that the majority of respondents in both conditions support public health department. And then we start to see lower levels of demand at the $100 and $250 levels, which is what we would expect. People are less willing to pay for a good or service the more that it costs them. The other thing to note here is that there are not any statistically significant differences between those in the COVID-19 condition and those that received the lead condition. And what this tells us is that the demand that we are seeing for a local public health department is not being driven just because of the current COVID-19 condition. This is reflecting some latent demand as well. Okay, so now that you've seen these general trends, I'm going to show you the same results broken down by subsample. And for each of these subsamples, I'm going to cut it to just the $5 and the $25 cost levels. And I do this for a few reasons. First, the trends for all the subsamples mirror what you see on this slide, but having just two data points to look at is much easier to take in. Second, a $25 annual tax exceeds what my own back of the envelope calculations are for what other counties pay for public health departments. For example, my rough calculations from Chester County, Allegheny County, and New York City suggest that the taxpayer cost of a public health department in each of those locations is less than $10 per year. So realistic estimates of the cost of a public health department are likely in the under $25 year range. However, I just want to say that I'm not trying to hide any data here. I have the full analyses for these subsamples, and I'm happy to provide them with anyone upon request or pull them up in the Q&A if you have questions about them. Again, they'll mirror the exact trends that you see on this slide, but I'm happy to share them with anyone. Okay, so moving on to the subsample analysis, we see that for both men and women, there is overwhelming support at the $5 annual cost and strong majority support for both genders at the $25 annual cost. And you can see that there are no significant differences in demand for women nor men. And that trend continues at the higher cost levels too. Across age groups, we see strong support at the $5 annual cost, over 90% of people voting for the referendum. And at the $25 level, we still see strong majority support across all age groups. At this $25 level, you can see that the error bars start to not overlap, which suggests that demand among the younger age groups, so those 18 to 34, starting at this $25 level, demand a public health department slightly more than the older age groups. And that trend continues to the higher cost levels as well. I'll also note that the $50 cost level, which is not shown here, at that level, there's still strong majority support across all age groups. We see similar trends when we break it down by education. So with 90% or more across those educational groups voting for the referendum at the $5 annual cost level. At the $25 annual cost level, we see majority support across all educational groups, but with higher demand among those with higher education. And again, that trend continues at the higher cost categories as well. And again, when we cut our sample by political affiliation, we find similar results. We see 90% or more Republicans, Democrats, and independents voting for the hypothetical public health department at an annual cost of $5 or more. At the $25 annual cost level and above, we start to see differences by political affiliation with stronger support among Democrats and then independents. However, it is important to note that even at that $25 annual cost level, we still see majority Republican support. Okay, so when we break it down by race and ethnicity, again, we see strong 90% support or more for a public health department across race and ethnic groups at that $5 annual cost level. And at the $25 annual cost level, we see majority over 50% support across all racial and ethnic groups, though lower demand among non-Latinx whites. And this trend also continues with slightly lower demand among non-Latinx whites at the higher cost categories as well. Even though at the $50 annual cost level, there is still majority support across all categories. And then the final subsample analysis, which I'll show you, is income level. So again, we see similar trends when we break it down this way, with over 90% support across income levels at the hypothetical $5 annual cost, and majority support at the $25 annual cost level. And we don't really see strong significant differences across income groups. At the higher hypothetical annual cost of $50, we see a strong majority support across income groups. And at the very, very high cost of $100 and $250, we start to see slightly higher demand among higher income respondents compared to lower income respondents. Okay, so that was a lot of graphs, but just a few takeaway points here. When we look at the overall sample, we observe really high levels of demand for a public health department, with 59% saying that they would vote for the creation of a public health department at a $50 annual cost level. And then no matter how we broke up the sample, over 50% of respondents supported the public health department at a $25 annual cost. And again, looking at other counties in Pennsylvania with public health departments, the cost to taxpayers in those jurisdictions was less than $10 per taxpayer per year. And finally, 90% of every group always supported a public health department at a $5 annual cost. So taking this all together, the main takeaway point is that we see fairly universal and pretty high demand for a public health department in Lancaster County. So I'm going to end there, but I'm happy to answer any questions in the Q&A about the survey methods or findings, and I look forward to hearing from the panelists next.
Hi, everyone. Thank goodness, Dr. Meyer, you got to the graphs, because I was losing my concentration trying to follow all the methodology. But it's good to know that it was done so scientifically and so fairly, and I really, really appreciate the work that you've done behind this and to support polling and scientific polling in general. It was great. I'm hoping everyone else does a better job of following it. But I'd like to get all of us talking at this point in time. So I think what we'll do is I'll introduce everyone, and then when I introduce you, just take a minute or two to just maybe explain what you do for community health and how you're involved in this. And maybe that explains very easily why you're on this panel. But let's start with Elisa Jones, the head of the Fairly New Union Community Healthcare Center. And that is a merger of two federally qualified health centers. And so you have an enormous amount on your plate, Elisa, but please introduce yourself and tell us a little bit about how you interact with the community. And you're gonna have to, everyone's gonna have to unmute themselves. I'll just remind you.
Thank you, Susan. It's a pleasure to be here with you all. My name is Elisa Jones. Between Lancaster Health Center and Welsh Mountain Health Center, we have merged together. So you have 50 years each of community health experience. So together we have 100 years of serving both the Lancaster and Lebanon communities, specifically as your community health center. So we focus on serving folks of low income and folks who face barriers to care, including lack of insurance.
Nice. Thank you, Elisa. Can we move on to Dr. Livingston? Dr. Cherie Livingston, and you are with UPMC Lidditz. Please tell us a little bit about yourself.
Sure. One, I'm honored to be here today amongst an excellent panel, and I look forward to engaging in great stimulating conversation with our guests. I'm Dr. Cherie Livingston. I am an OBGYN who's been practicing here in Lancaster since 2006. I was born and raised in our neighbor, Harrisburg, Pennsylvania, in the projects of Harrisburg, so I'm happy to be on this side of life. I'm an OBGYN department chair at UPMC Lidditz. I've been recently designated the Diversity, Equity, and Inclusion chair at UPMC Lidditz. I'm a member of Patients Are Waiting, and board member and organizer. I work alongside Dr. Cherise Hamblin, who's the founder of Patients Are Waiting. Patients Are Waiting is an organization, nonprofit organization, whose mission is to eliminate health disparities by increasing diversity in medicine. I'm a co-founder of the Diversifying Doulas Initiative, which has increased the number of Black and Brown doulas here in Lancaster by 900%. So we're very proud of that. And again, I'm excited to engage in really awesome and stimulating dialogue, as I think this mission is important and necessary.
Thank you, Dr. Livingston. I'd like to move on to Dr. Okach, who I've worked with over the years. She's from F&M. Dr. Okach, would you like to introduce yourself?
Sure. Thank you very much, Susan. My name is Harriet Okach. I am an assistant professor of biology and public health at Franklin and Marshall College. I enjoy and spend a lot of time interacting with community in Lancaster, particularly on the issue of lead poisoning and lead poisoning prevention. So I have done and completed a few projects, some of them working with Susan Baldridge, on understanding how community members understand the issue of lead poisoning and thinking about ways that collaboratively we can address lead poisoning and think about, I'd like to call them indigenous to Lancaster solutions that we can use. I also sit a member of the Lancaster Lead Coalition, and so really interested in addressing that issue. Thank you.
Wow, we've only heard from 3. Aren't these women amazing? Dr. Phillips, Dr. Carol Phillips, could you introduce yourself? I've known you for a long time, but there's probably a few people in Lancaster County that haven't met you yet, so please introduce yourself.
I grew up in Nashville, Tennessee. I'm a registered nurse since I was 20 and have actively been engaged in nursing education since that point in time. I retired since I'm now an old girl several years ago, but I still maintain active commitment on committees like Partnership for Public Health and the work that I do at Lancaster General on their quality committee. I also, though, in an advanced role, I'm a big supporter of our community, and I'm president of Borough Council, and the lead issue is a huge one. We're one of the oldest boroughs in the state, and of course, As you may know, Lancaster City is the oldest
It's Manheim Borough.
Manheim borough. Did I say that wrong? Oh, it's my borough, yeah. But we've had a lead issue, and I'm working diligently getting our zoning officer to add testing on a routine basis.
Thank you. Thank you, Dr. Phillips. We're going to move on now to Dr. Catherine Schmitz, who is from the Penn State Cancer Institute and very involved in public health. Catherine, Dr. Schmitz, would you like to introduce yourself?
Sure. Thank you very much for the invitation to join this illustrious group. I am Distinguished Professor of Public Health Sciences at Penn State College of Medicine and Penn State Cancer Institute. I think my contributions to public health, start with the fact that I teach in our, MPH and doctoral level DRPH and EPI-PhD programs. So I'm training the next generation of public health scientists and practitioners. But in addition to that, my research is on exercise very specifically in the setting of cancer prevention and control. And I lead something at Penn State called the One Group, Oncology, Nutrition, and Exercise. We have a website that's not hard to find. If you type in One Group and Penn State, you'll find it. And in response to the COVID crisis, our team built an entire exercise program for cancer patients and survivors that can be found at our website. And you can find out more information about the various clinical trials that the 14 investigators of the One Group are doing. But my connection to community is twofold. One, I chair the Community Advisory Board for the Harrisburg Area YMCA, but I'm also on the ballot in Camp Hill, Pennsylvania, as judge of elections. And I'm eager to do whatever I can to ensure safe, fair, and timely elections.
Great, Dr. Schmitz. Thanks so much. Now, last but not least, we have our own Lancaster Alice Yoder, who's been so involved in public health over the years for Lancaster General, which is now Penn Medicine. And I'm sure she's used to going last because her last name starts with a Y. So Alice, to the two people that don't know you, please introduce yourself.
Hi, everyone. And I think at some point we need to go like alphabetical order by first name.
Right.
Wouldn't that be?
There you go.
Okay. Well, hi, everyone. I'm really happy to be here and certainly among the company that I'm with these remarkable women. So, so happy to be here. And in the spirit of celebrating Women's Month, in terms of things that I've done and a little bit of background about myself, I think first and foremost, my main responsibility at Lancaster General Health, I'm the Executive Director of Community Health, and the main responsibility is to conduct a community health needs assessment and develop a community health improvement plan. So my esteemed colleagues here, as well as many community partners, help us do that. And we've been doing that since the mid-90s. So we based most of our initiatives, if not all, on the results of the needs assessment, working with the other hospitals on that as well. But over the years, I've had the privilege of spending 4 years as Director of Maternal Child Health for Lancaster General, where really framed a lot of issues as it relates to women. During that time, I oversaw Healthy Beginnings Plus and helped expand that program, as well as Nurse Family Partnership and the Sexual Assault Program, as well as domestic violence policy. So just to name a few things that significantly excited about as it relates to women. So that's a lot of the work. And lastly, what I would say, when I think about some of the community boards that I'm on, I am the chair of the Lancaster County Planning Commission. And just to say a little bit about that, the connection there is from a planning standpoint at a county. The planning commissions, typically you think about roads and buildings and ordinances, but I'd like us to think about from a public health standpoint, how all of that really creates an environment or is not a good environment for how we create healthy communities. So I am excited about being on the planning commission, certainly excited about being chair, but also really important how we see the connections about how we build our community and public health. Thank you, Susan.
Oh, thank you, Alice. So I do want to come back to the survey in a few minutes, but I think there's an elephant in the room. And so someday we'll have conversations that don't have the word COVID in it. But until that day comes, I had a chance to really reflect with my own family about some of the differences, some of the things that we learned over this last year. And I'd like to ask anybody if they have something they'd like to share with a learning experience or an insight that they gained during this COVID epidemic that they would take forward and perhaps use it in your practice or in your everyday life or in your professional life, that you were changed during COVID for this reason. Oh, Dr. Schmitz, please.
I'm just going to jump in and say
Sure.
that what
Everybody
has become
jump in.
so completely obvious to me and my colleagues and the people that I've been talking to is that, we have a generation of people who have not received sufficient public health education. I think that we have a massive need for educating, down to elementary school level, but, the general public about the value of public health. People have forgotten about what the vaccines have done for us in generations past. So I think that that's the first thing that pops to my mind. Is it makes it. I mean, we knew before COVID that people didn't really understand public health, but now we really understand why it is so crucial that they do.
Thank you, Dr. Schmitz.
I'd love to answer that question. When I look back over this year, the phrase, "I'm a Black woman, but treat me like I'm a white woman," takes on a completely different set of meaning. 1 in 555 Blacks died of COVID. If COVID did anything, it unveiled the disparities that exist between people of color and the white community. And it's painful. It's painful to not only see it, but live it. I have family members who have been impacted by COVID and who have died from COVID. And I just know that if you didn't have a reason to act, you have one now. And that's the phrase that I think of when as an OBGYN, when I see, say, for example, a 40-year-old African-American pregnant woman walk in my room, besides being terrified because I know all of the risks that are present just from her being 40. So she's at advanced age. For being African-American, it's almost like being Black as a pre-existing condition. And then the possibility of comorbidities. I have to put her into what I consider to be a VIP category. I treat her differently. And it's strange to say that as a doctor. But I think if I don't do that, I run the risk of her falling victim to the increased maternal morbidity and mortality that we'll talk about later.
But how do you treat her differently?
Good question. For me specifically, I listen to her. That's the first thing I do is I listen to her and gain her trust. I look her square in the eyes, and when she says certain statements like, "Jesus will handle my medical condition," I know that what she means is not non-compliance, but what she means is in her community, what's valuable is having faith. So I don't dismiss her because she's saying, "Oh, Dr. Livingston, I know you told me my blood pressure is up and I need to lose, a couple pounds and stop eating sugary foods during my pregnancy so that I don't gain 75 pounds." When I say all those things, and then she says to me with the straightest face and the most serious face, "Oh, Jesus will take care of me," I don't dismiss her. I listen to her, and I encourage everybody on the line, and I'm not assuming you guys don't do this. I'm one with some awesome people who I would let take care of anybody in my family, myself included. But I encourage you to, number one, listen and gain the trust, because once that happens, miracles start to happen. people believe that you're invested, so maybe they become invested, they follow your recommendations, and awesome care happens.
That's amazing. Dr. Oketch, did you want to add to that?
Yeah, I'm actually thinking of, taking Dr. Schmidt's response and Dr. Livingston's response and thinking about the Introduction to Public Health course that I taught in the fall. And we talked a lot about social determinants of health. So first, I should say that there's an overwhelmingly increase in the number of students who are interested in public health. And it's probably one of the positive outcomes of COVID that we're getting a generation of people who are really invested and interested in understanding a little bit more about what public health is and how to address it. And one of the topics we talked about in that class were the social determinants of health. So moving away from this idea that, poor outcomes of health are solely going to be dependent on the bacteria or on the virus or these etiological causes that are microbes, and now starting to think about, the way that we have shaped the society that we live in, the social structures that we have. If you look at socioeconomic status, if you look at education levels, if you think about the built environment where we're living, if you look at race, that all of these things impact on the outcomes of health, right? So if COVID alone is being caused by this SARS-CoV-2 virus, why is it that Black people and people of color are more disproportionately affected? Well, it's because of all the other social structures. And so if we follow on Dr. Schmidt's conversation about taking public health right to elementary levels, how do we demonstrate right at elementary levels going up that this is an important aspect? At the end of the class, I did ask the students, of all the topics we discussed, what's the one that really stood out at you the most? And 90% of the students talked about the social determinants of health as being something that was very big for them, that they really were awakened to, that they hadn't paid a lot of attention to. And so I would like us moving out of COVID and moving forward to take this understanding that we really can equip the next generation with understanding of how the social determinants of health play a role in health outcomes.
That's fascinating. And I think we could get a firsthand sort of insight into that. Talking to Alisa and Alice, you guys were both on the front lines of COVID in Lancaster County, both with testing, with contact tracing, and with vaccinations now. And what were you seeing along the lines of the three doctors that just spoke? What were you seeing that maybe opened your eyes a little bit about the social determinants of health?
So as a community health center and a federally qualified health center, we were, we understood from day one that it was our responsibility to take the correct public health actions, but to take them with the lens of who is most likely to be disproportionately negatively impacted. So I'll give you an example. By definitely this time last year, but even towards the end of March, we were asking folks to stay at home, to work from home. If you were exposed, you were supposed to quarantine away from your family. And there was even messaging saying, use a different restroom. That assumes you live in a house with multiple restrooms. That assumes that you don't live in a family, in a home with 3 generations, children, mom, dad, grandma, grandpa, auntie, uncles. It also assumes that your job can be done from home, that you work on a computer, that you're most likely educated, that you're a professional, that you have access to reliable internet that's not on this device that you pay for once a month with reloading a card. So there were so many assumptions made about how to protect yourself that had no basis in the reality of the lives of the patients that we served. So these folks worked in manufacturing, in food service, in agriculture, in service industries. Many of them were housekeepers. Cannot be done from home. There was no coverage for their job. There wasn't opportunities for them to say, I'd rather just kind of stay at home with my family. So we had to quickly kind of interpret these things that were coming from the national and the regional level and saying, okay, not applicable to our patients. How do we help them to be able to be as safe as possible? So we had to develop protocols. When we started contact tracing, we were the first in our area to begin contact tracing, to say, okay, this is what it looks like after you use your family restroom to protect the next person. This is what it looks like to carve out some space if you can. This is what it looks like to open windows. This is what it looks like to be able to talk with your employers. And we had to develop relationships with some of the employers that we were seeing many, many cases come from to say, how can we help you support safety in your own workplace? Because a lot of your workers are being infected. And of course, these were not the workers who were making six-figure salaries. These are the folks that are making minimum wage. So
And a lot of women. A lot of women.
Yes, a lot of women. So I can't tell you that we were surprised though, Susan. So we do this work for a living. This is what we do day in and day out. So it wasn't a surprise. It was just a tsunami that we had to prepare for and appropriately prepare our patients for.
Yeah, so I would say the biggest learning for me was the value of relationships and partnerships. I've always have a strong, one of my guiding principles looking at complex issues within the community and thinking about how to solve them has always been collaborative, and it's always worked out well from the standpoint of knowing that no one organization, no one person can solve an issue. I always felt that way, but it played out for Lancaster County in my mind because of through this pandemic. I think that was my biggest learnings. From the time we set up the testing tents out at the PA College until now with the vaccine, I remember day one when we were out, the tents had just gone up and the staff was coming. It was like 6:30 in the morning and we were thinking about how to do all that. I got a text early on from the folks at Water Street Services about what they need to do. And they knew they had a really good plan already about what they needed to do for the people within their shelter and others and how they communicate with those that are unsheltered and on the street. But they needed some more information. And right from the get-go and through the whole parts of the pandemic when we moved into contact tracing and now into the vaccine, those relationships that were built in non-pandemic time, both with Lancaster General in the community, but then among the community, I'm sure you've all seen this. To me, I was in awe about how the community worked together. And I think that we were better through the pandemic because we had those relationships going into this, that we were able to pull together more quickly and I think more constructive because everyone came together because they knew each other. We had some relationships already. There was somewhat of a level of trust, if not a lot of trust, that helped make that happen. And I think that, and particularly now with the vaccine, looking at vaccine distribution from an equity lens and knowing that when we think about equity, we think that we can't just give everybody a one place to go. We can't just give them, here's the shot, go for it. So, we're seeing these pop-up clinics that are occurring, and they're occurring in partnership and relationships with faith-based organizations, other organizations that work specifically with either the Black and Brown communities, the refugee communities, folks in Colombia and some of the Black churches in Colombia. And those clinics, in my mind, are working effectively, meaning that the ones at least that we've done, 80% of the populations we've had come to those clinics when we've given out 500, 300, 130 have been people of color because of those relationships and because of doing that in partnership. So that whole connection to me, I've always felt that way, but I've never felt stronger about it until now. And that's a big part of what I've learned.
That's amazing to hear you say that, Alice. I think that carries a lot of impact on it. I want to go back to something that Dr. Schmidt said and Dr. Okach about the increased interest in public health, but the lack of education about public health. Dr. Phillips, were you surprised at all to hear in the news that during COVID, that an increase in nursing there's been actually an increase in interest in nursing and medical fields, despite the danger and the stress and that kind of thing from interacting with COVID patients, both in a hospital setting and a non-hospital setting. But were you surprised, and what do you attribute that to?
I am not surprised. And it's because in many ways, I think our young people are getting it in big kinds of ways. And I think that particular, I will look at the old medical model. I am very impressed with the family medicine model that has begun permeating through our county, where you don't drop your kids off to a pediatrician and that the whole family comes. We look at things together. We did too much warehousing, I think, once upon a time. I even worry to some extent that some of the elderly stuff, you know, that just all these retirement communities that are segregated off, but a number of them are working harder to integrate, I think, the generations, what's happening. But our young people, from what I've seen, I'm very impressed. And our numbers going into nursing at Millersville, all the way to the doctoral level coursework these days is phenomenal.
I find that amazing, but I also find it a commentary on women in general, because it's majority of those going into nursing, not all of them, but majority are women. And just listening to everything that this panel's doing can make you tired, or can make you get off the couch and say, you know, I need to join the effort because these women are doing so much. So we all need to jump in there, both with consciousness raising and just what we do for our community. I want to get back to Dr. Schmitz for a minute about what you said about the lack of public health education. How are you seeing that exactly? Just in a, from your students or from your colleagues, or how are you seeing that?
I'm seeing it in mass media. I'm seeing it in, you know, when I look at, you know, we're very careful at our house. We have quite the balance of types of media sources coming into our home. And because of that, I'm seeing things from more conservative as well as more liberal sources. And it's really clear that, you know, public health has become politicized. And, you know, so there's this idea that somehow it is taking away from your freedoms for us to pay attention to public health issues. And that is lack of education. I mean, that's just straight up lack of education. And so, and I think it's going to take us a generation to back our way out of that. So that's where I'm seeing it. I'm seeing it in you know, in mass media, and a lot of sources in mass media.
That is true. I'm sure everybody here in public health has said to themselves, oh, why are they saying that? Yeah. That's not true. and there's so many sometimes conflicting messages. But going back to the survey, one thing, Dr. Meyer, that really struck me, and maybe it didn't surprise anybody else, but the thing that really struck me is the strong interest in public health, despite political party, despite socioeconomic levels. There is a very strong push for public health. So I'll put this out to all of you. How do we get politics out of it and have it a community conversation and a community decision, and not always have these messages like masking wrapped up in politics? Anybody have any insights on how we can the politics out of public health? Now, don't all you jump in at once. Well, I think one thing that I've been reflecting on is I think we need more community conversations like we're having today about public health. I think one thing COVID did for us is it brought the importance of public health certainly to the forefront of everybody's daily life, and for all of us who work in public health, it brought it to our professional life too, the need for public health. So
Susan, can I just jump in with
Please.
one thing? One answer that I have seen that I think is a really positive move is some people might be familiar with, on NPR, there is a project called StoryCorps. And they actually have started a project where they're bringing people together, that, you know, there is a growing desire of people on you know, disparate sides of political fences to find ways to interface with someone who believes very differently or thinks very differently than they do. And so StoryCorps has created a space to do that.
now, is it specifically about public health, or can it be
No,
about it?
It can be about anything. But I think that the point is I mean, I can't tell you how many, I live in an extraordinarily purple place, Camp Hill, Pennsylvania, and, very, very mixed. And, a lot of different kinds of signs in the yard. And, I would love to have a conversation with my neighbors who obviously feel differently than I do based on the signs in their yard. And I have no idea how to start that. So I think that I think there's a desire for people to have conversations. And what I think would be interesting and what I think could be sort of a neat project is talking about public health might be sort of an initial safe space for people who feel quite differently. That might actually be a place where people would be willing to come together and talk, so they don't have to talk about the politicians that they like or don't like.
That is a very good suggestion. So can
I'd like to jump in here. I think when you ask what can we do to make this situation less politicized, I think we continue to remain steadfast with relying on facts. I think people are inherently intelligent and they understand information, they understand facts. So for example, I wanted to know how many of our women here at our hospital received the COVID vaccination, because we were doing some research with COVID in COVID vaccination and pregnancy. And so I did a 122 person survey and learned that approximately 52% of our staff who were of reproductive age had received the vaccine. And so we sat down, we talked about this data and talked about what were some of the reasons for hesitancy and why we, a medical institution, weren't at 100% of our staff receiving the COVID vaccine. And by doing that, we were able to open up doors and share information about the vaccine's safety and pregnancy. But again, I think we continue to collect information, share information, and I think that'll make this a less political situation. I think it'll always be, but we can surely work towards lessening it.
So Dr. Okatch, what would be a very pure and basic description of public health? What do you tell your students?
I tell them that defining public health is really challenging. But a simple definition of that is when you're thinking about public health, you're thinking about the health of the public. How do we promote that? And how do we make sure that every person can attain the same level of health, which really is a human right, regardless of where they come from, which zip code they live in, what color they look like, what level of education they have. And I make sure that they do understand that, therefore, public health is not necessarily something that a doctor gives you, right? Like going in to see a doctor is one of the ways to attain it, but it is not the only way to attain it. And I also bring to them this idea that we can, each of us, contribute to improving the health of the general public. And so if right now we're looking at this particular highly transmissible disease, COVID, what can I do to make sure that my neighbor remains healthy is how I can contribute to the space of public health and promoting that. So just thinking about generally the health of every single individual, and that every single person has to attain the highest level of health regardless of their background and experiences.
That is a really good basic definition. And I think in the past, now I'm fairly old, but not old enough to really remember the polio epidemic, which I don't think that was politicized. I mean, someone correct me in public health if I'm wrong, or outbreaks of typhoid fever, what we did, yellow fever, smallpox, things like that. When measures were taken to control those outbreaks, I just don't remember there being this big political controversy around it. And correct me if I'm wrong, Dr. Schmitz, but isn't there a lot of things that have been improvements to our life through public health?
Yes, Yes, yes,
For our
many.
longevity.
Yes, yes. You know, the first sort of famous oldest tales that we tell our students in public health are about, you know, the idea of, you know, the women who were, you know, in the surgeries of, you know, these physicians who didn't believe in the germ theory, and they would, you know, in order to spite the germ theory, they would wipe their knives on the ground, and they would wipe their knives on dirty things to show how ridiculous the germ theory was. And of course, more of those women were dying, you know, and so, you know, so we can go back as far as, you know, John Snow and cholera, and, you know, the Broad Street pump, and, you know, water supplies. I mean, you know, the first era of public health was really sanitation. And so, you know, there have been actually a few really sort of cute, funny, you know, pieces in media actually that have talked about, okay, well, you know, you don't want to wear a mask. I also don't need to clean your water. There doesn't need to be a sewer system. I mean, these are the most basics of public health. You know, we do seem to have, as society, an agreement that we all want to have water that we can drink that doesn't make us sick, that we would have sewers that work. We have, you know, certain things that we do have agreement on, you know, that we don't even know. They're so baked into the infrastructure that we don't even think about them anymore, you know. But maybe it's time for us to highlight those. Maybe it's time to make the obvious, you know, or make the stuff that's sort of behind the scenes more obvious to everybody, so that they see that there is actually an infrastructure. I mean, we saw it break down. We saw the energy infrastructure break down in Texas, you know, in Austin with the storms, because they privatized it. It was no longer a public good, you know. So I think that there are a lot of things that are that have been around for so long, we don't even know they're there, right?
Susan? Correct.
Yeah, go.
Following on that, you mentioned the polio epidemic, which I remember the first one since I was old enough.
You
And
dated
we got
yourself.
the Salk vaccine and the same, but do you remember the one that happened in Lancaster County later among our Plain community? And we lined up in droves and got everybody revaccinated. We need that kind of energy around these sorts of things.
I couldn't agree more, Dr. Phillips, but you are dating yourself by saying you remember.
Well, it's okay. I'm still around.
You know, and let's jump off of COVID for a second. I think there should be some relief about that, but I do want to add one thing. Like when Dr. Schmidt said there's things around us, what about seatbelts? What about wearing shoes into stores? There's just so many things. What about, you know, child abuse laws that are for the greater good, which everyone's talking about, for the greater good of everyone. And we realize that. So I guess that's the goal of public health, is we realize that thinking about the greater good is a positive, not a negative. So I want to talk about something else beside COVID, and that is a subject that's near and dear to my heart, because I covered it as a newspaper reporter for almost 5 years, and that was the opioid epidemic that hit our community very, very hard, as it did many other communities. But one thing recently that I became aware of, and I wonder if Dr. Livingston could comment on this, is that pregnant women with addiction issues or struggling with addiction may have more challenges here, because we're new to this. We don't know really what we're doing. And we are learning from other communities that women who are pregnant can have multiple issues and backgrounds that we, you know, as a medical community then are not really addressed. What would you say about this, Dr. Livingston?
So the United States is one of 13 countries whose maternal mortality rate has increased over the past 15 years. That is very concerning for a country with our level of resources. And so to answer the question specifically, comorbid conditions like cardiovascular disease is the actual #1 cause for death in pregnant women. But 5 years ago, the opioid crisis led to a huge uptick in the number of women dying of overdose. And so what we are focusing on is the initiatives set forth by the CDC to really focus heavily on decreasing the maternal morbidity and mortality crises. Pennsylvania has a maternal mortality review committee made up of several wonderful maternal fetal medicine specialists, and we use this committee to review deaths annually. And we look at causes, and our goal is to obviously reduce this trend. 700 women die every year in the United States due to pregnancy and childbirth complications. So it is extremely important that we address this. Black women are actually 3 to 4 times more likely to die in childbirth. And ways to reverse this trend and deal with this trend is to look at what's the predisposing factors, such as heart disease, hypertension, diabetes. We can rely, obstetricians are not going to fix these problems of substance use disorder in pregnancy, comorbid conditions like diabetes and hypertension. We will not fix it alone, so we do have to rely on our certified nurse midwives, doulas, maternal fetal medicine specialists, obstetric psychiatrists. We're all addressing this as a team. And so just so that the panel knows and the listeners know that we are focusing on these deaths, we review them annually, we look at them very intensely so that we can obviously reduce this unfortunate trend that the US is seeing.
So how is your diversifying doulas, how is that, how could that impact this maternal morbidity and mortality? How, I don't understand that.
So doulas, let's start with explaining what a doula is. A doula is a non-medical birth assistant whose primary goal is to advocate for the patient. And by advocating for the patient, they promote information while the woman is in labor. They help her emotionally, physical support. So she essentially becomes a support person. And we created the Diversifying Doula Initiative out of a need. Necessity is the mother of invention. And Lancaster County, as of a year ago, had 1 Black doula. And we have now, to date, 36 Black and brown doulas who are certified here in Lancaster County. And there's research to show that having a doula, especially for women of color, having a doula helps to improve breastfeeding rates. It decreases your likelihood of having a cesarean section. It decreases preterm birth. Having a doula decreases postpartum depression. So there's science to support this. And so we have created this Diversifying Doula Initiative with a mission to decrease, obviously we know we won't eliminate maternal morbidity and mortality, but decrease Black and brown maternal morbidity and mortality by increasing access to doulas, but also increasing the number of doulas of color.
So,
and yes, I noted I said pregnant women instead of pregnant people.
I did the same thing. So for pregnant people who want a doula, but they don't fall into a category that I think could afford a doula, because I would have loved to have a doula when I had children. So are they available to all different levels of socioeconomic living?
Well, sure. Doulas are readily available. So let me back up here. The average cost of a doula is about $700 to $1,400. So having a
That's a
doula
lot of money, though.
it's a lot of money, but good for doulas. They're able to earn a good income.
True.
The doulas that I
That's
know
true.
and that we see are amazing, and they can turn this into a great entrepreneur activity for them. But the average cost is about $700 to $1,400. So that's cost prohibitive for people who can't afford it. The problem is the people who need a doula based on the scientific evidence can't afford it. And so that's why our Diversifying Doula initiative really dug deep into our mission. The Diversifying Doula initiative was built from our Patients Are Waiting organization, whose mission is to eliminate health disparities. So if the Patients Are Waiting organization is made up of 3 Black OBGYNs. So it's sort of in our DNA to care about maternal morbidity and mortality. And we saw a problem, which was 3 to 4 times more likelihood for Black women to die in childbirth. And we said, let's widen our lens. OBGYN doctors are amazing, but we're not going to fix this problem alone. And our certified midwives are obviously helping to reduce mortality and morbidity, but doulas are highly effective in getting this done. We're seeing it in the science. We are actually using our DDI initiative to collect research, so we will have research readily available for Lancaster County and beyond to show just how important both personally, professionally, and scientifically doulas are to our community.
Wow. So I have the next subject for United Way. I think we need to talk more about this. I'm fascinated. I'm sure other people are too. Alice, do you want to jump in here?
I did. It just made me think about so many other elements, but specifically pulling in the concepts of mental health for all women, let alone people that are pregnant, and what pregnancy can do from that standpoint in terms of stress, but also the connection between that and 2, I think, significant elements that I thought was going to be said by now is around income and racism. So, when we talk about infant and maternal mortality, morbidity, and really thinking about root causes and some of that, part of that conversation, and again, perhaps for another time in terms of talking about that, but a lot of other things that we can discuss here, I think to some extent would be a Band-Aid, which is fine because you think about primary, secondary, tertiary prevention. But when we think about going upstream and starting to address those, it was already mentioned about social determinants of health and others. But I think when we think about public health and we think about the history of public health, going from, sort of antibiotics, understanding disease, then getting into understanding how the environment influences our health overall, where we live, work, learn, and play. And then sort of the next generation of that is the understanding of public health and those social determinants that necessarily wouldn't be considered what we would consider a public health department. But it's sort of, I think several people mentioned it, sort of the impact of education, of income, the effects of racism as it relates to disparity. So I think just this discussion we were just having just made me think that, a lot of the things we do are sort of Band-Aid approach, but to take the step back and think about a healthy communities, those are some of the issues we need to have a broader discussion about.
Susan, could I just weigh in real quick there?
Yes, Elise, I was going to ask you, there is an initiative related to this that your facility has started that would address one of those social determinants of health, specifically for pregnant women. Do you know what I'm talking about?
Of course I do.
You can tell everyone else.
Yes. So I wanted to build on a concept with which Dr. Livingston and Alice both mentioned. And the concept is really around the life course perspective. So that is, best practice, science-based way of thinking about the health of health of folks who are pregnant, but also looking at it from a bigger lens, right? So sometimes we think about pregnancy as 9 months. And if you have a healthy baby, it's what you did or didn't do during 9 months, which we know is actually not true. Whether you have a healthy baby can be based on what your grandmother had access to, what your mother had access to, and then what your entire life before you got pregnant you had access to. It's a life course. And very important for us to remember, the health of that baby's baby depends on what services and resources and stress that individual who is pregnant is living within. So that's where Union Community Care, we have a program which we call PROUD. It's really perinatal opioid use disorder services, where we really try to reduce barriers that folks have when they're accessing resources. So if you are receiving, let's say you're receiving medication-assisted treatment for opioid use disorder, you might have to go here. If you're going for your prenatal visit, you might have to go 10 miles down the road. If you're using public transportation, that's an additional 2 hours. It's time off of work, potentially. It's time away from your other children. So by bringing both the medication-assisted treatment, if indicated, by bringing behavioral health, by bringing the clinical services, all under one roof, we have this kind of one-stop shop approach. And then partners like Healthy Beginnings, the STEPS program, the RAISE program, all these wonderful partners that are doing beautiful work in this space, they come to where the patient is. Imagine that. Imagine services come to you instead of you have to figure out how to get to different services. So again, reducing barriers. So that's one of our programs that we're really proud of here at Union Community Care. But I just wanted to quickly say one more thing, which is speaking to Alice's point. We must start to think of intersectionality, okay? So these things aren't separate, and there isn't one magic pill or one magic thing that we can do. They are all at an intersection together. So if it's racism and sexism, racism and homophobia and sexism, geography, ability level, language that we speak, all of these things are at intersections. So anytime we think there's one answer, we should always kind of smack ourselves. There isn't one answer, because we are not understanding the dimensions, what the dimensions that everything works through. And the dimensions, those intersections, that is public health. It is at the intersection.
So Dr. Okach and Dr. Schmitz, how many of you want to have Lisa Jones teach one of your classes on public health?
I definitely would. And actually looking forward to inviting her to my class and just listening to her talk about it. I'm so glad that everybody who's listening to this actually now can see applied public health, right? So my talking about what public health is was a theoretical description of it, but listening to Elisa really puts into perspective that this is what applied public health looks like, and where you're really thinking about how do we prevent disease, how do we promote health, right? And if we can do those two things, and in the way that she describes it, then we're going to prolong good quality lives, you know? So I definitely look forward to having her teach my students.
Of course, I could keep listening to her. But Alice, I wanted to talk to you about, I think you were probably one of the first people in the county to bring up social determinants of health as really an important way to look at public health. And I was wondering if you could fill in some surprising, I know I'm putting you on the spot, some surprising social determinants of health that are sort of unique to Lancaster County. I mean, the first one that I think of is our plain sect population, which is quite large. And there's a lot of things that they're born into or that are in their lifestyle that make their public health different than maybe another group. Can you talk about that a little bit? How you see the whole patchwork of Lancaster County being unique, I guess, is my question.
So I don't know that I'm sure about your question. Do you want me to talk about the Amish? Or do you...
No, not necessarily. But what I'm saying is, Like we all think that Lancaster County is a very unique place. This central Pennsylvania is a very unique place, but you have a lot of experience with different populations.
Mhm.
And can you talk a little bit about that, about how those social determinants are unique to Lancaster? I just used an example.
Yeah, so, you know, when we think about Lancaster, probably some of the social determinants of health that come up would be one of the first things that come to my mind, even based on the community health needs assessment, is around housing that we typically don't think about. So I know when we conducted the needs assessment in 2019, before that it came up a little bit, but in 2019 it was pretty loud and clear that affordable housing, working family housing was really limited. So certainly not even thinking about the city, but throughout the entire community. So you have people that you know, spend more than 30% of their income on where they live. And so it just reminds us to think back to those of you that have taken any type of sociology class or anything like that. I know I kind of shake when I do that because I think about the exam and Maslow's hierarchy of needs, which you had that triangle and you used to have to label each one. And I was like, oh no, kind of had to just memorize it. That was back in the day when you probably shouldn't memorize it. But anyway, I don't think there's a week that goes by where I don't think about Maslow's hierarchy of needs. And when you think about the core, the foundation is food, clothing, shelter. So a house, that's where the house comes in. So we can't think about going up that to that pinnacle of self-actualization. We're all reaching to just self-actualize, feel good about our lives. But if we're not sure about how we're going to put food on the table, if we have a roof over our head, and whether we can clothe ourselves or our children, our family, it's difficult to get us to think about how we take our insulin medication, let alone pick it up from the pharmacy, be able to afford it. So really going back to that piece. So housing really popped in our last community needs assessment. And not only that, but housing then in different parts of the county, and that it's easy to get to a job. So you have to work. So it's like one is related to the other. So if we don't have affordability of housing, if we don't have it dispersed within our county, it's going to challenge us in terms of employers are sort of struggling because of that. And so there's that layer of housing. And the last thing I'll say about housing is that, you know, saying we have housing that's affordable alone is not okay. But is that housing safe? Is it clean? Is it something where we would all want to live in? And so that's another layer. So we can peel away different layers of saying, yeah, affordable housing is one thing, but what is the kind of housing that so far people have access to that might be considered affordable? And is it safe, clean, free of lead, and mold and some other things when we start thinking about that being a basic need that somebody would have before they move up, you know, up that pyramid.
And I think I want to get back to you, Dr. Oketch. I want you to answer this, but with our older housing stock in Lancaster County and in Pennsylvania, we have a significant lead problem, a significant lead poisoning problem in children. We are poisoning children at 3 times or more the rate of children that were ever poisoned in Flint, Michigan. And that is lifetime consequences that we are all paying for. And the frustrating thing for me as being in the Partnership for Public Health and also Lancaster Lead Coalition is we don't have the data at our fingertips because we don't have a public health department. And that's just the way Pennsylvania is set up. We do not have our own health data because we don't have a public health department. And that has really impeded a lot of work in the area of housing, lead, safe housing, is we do not know where these kids are. We do not know if there's a pocket of lead someplace. There's a lot of things that we could know better, childhood asthma being one of them, with our air quality, but we don't have the data because we don't have a public health department. So that's my speech for today. Dr. Oketch, what would you like to add to the lead conversation?
A lot, but I have to restrain myself and just add what I think is necessary.
Gets you going.
Yeah. So, I mean, when Alice started talking about housing, it brought to mind some of the findings that we arrived at when we conducted our study to find out what exactly contributes to the heightened prevalence of lead poisoning that we're seeing in Lancaster. So I think it's one thing to say that we have elevated levels of lead poisoning, but it's another thing to try and identify what the root causes are. And while we do know that older housing is a risk factor for lead poisoning, what interestingly came out from those surveys was this idea of rental status. So it's not just about having a house, it's whether you own it or whether you're renting. And you can understand that for renters, first of all, the transition, the turnover of rental properties is high. We have a critical shortage of homes in Lancaster. And so if you're renting, you almost have to take what is given to you. You don't have autonomy over fixing your home and preparing it and making it lead safe. And even if you did, you don't know how long you're going to be there for. Do you want to invest in something? So renters almost are at the mercy of the landlords. But even more interesting, several of our community members so trusted their landlords, they believed their landlords were going to make the home safe, right? And so as we talk about public health, we have to think about how do we get landlords on board to understand the importance of lead poisoning and how they can address it to make the home safe for the children so that a child is not poisoned before the age of 2 and end up in a criminal justice system at the age of 16, right? So these are important things to think about. Now, a lot of times, even applying for funding that would allow us to eliminate lead from Lancaster is very much dependent on data. We get data about lead poisoning. So lead poisoning is the only non-communicable disease that is reported to CDC. So when a healthcare provider does a lead test, that has to get reported to CDC. Those results are going to be shared with the state health department. It takes them a while to collate that data and combine it and publish it so that now any individuals in Lancaster organizations can then make use of that data. Sometimes it takes up to 2 years. I think they just released this month the 2019 results from the lead surveillance from the state health department. We're in 2021. So we are not able to use that data to act real time and improve the health and address, the most salient aspects of lead poisoning. Should we have a health department? If we did have a health department in Lancaster, this data would be more real time for us, allowing us to be able to act in a way that is really going to help the public and protect the children. Alistair talks about a life course. Lead poisoning is exactly the same thing. Children get poisoned when they're young. It impacts on the development of their brain. It affects their learning in school. Sometimes they might get held behind. They're at risk of higher suspension rates in school. Once they become teenagers, they're more likely to be involved in the criminal system. Kids who are lead poisoned are 8 times more likely to be incarcerated than those who are not lead poisoned. And now, if it has impacted on their education attainment, you can see how that is going to impact on their ability to get a job, but also on their ability to provide for the next generation of children who come. They're more likely to develop conditions as well as they're older, renal conditions and other conditions, cardiovascular conditions. So when we talk about lead poisoning and the necessity of having a public health department that can allow us to collect data in real time and act in real time, it's not something that we take lightly. It is something that is really heavy. And I think Professor Maya wants to say something. So I will stop because I could go on forever.
Well, I love it when Dr. Katch goes on forever. But I'll just point out, she was speaking about the long-term costs of the lead poisoning problem. And again, from an economics angle, there's a cost to having a public health department, right? But there's also a large financial cost to not having a public health department. Those are social services that we're funding, right? The increased incarceration rates, the increased education costs. And so just want to point out that when we think about the costs of a public health department, there's also costs to not having one. And I think that the lead problem in Lancaster really, really highlights those.
Let me ask a question that was posed by one of our listeners. I'm not sure who's the best to talk about this, maybe Alice, maybe Elisa, but how would you use data from a public health? If let's just say miraculously we had one and we had data, how would you use that in your own professional world? How would you use that to help the community?
I
I could give an example in pandemic times and non-pandemic times, but the most recent one was contact tracing. So when the pandemic hit, and we know one of the most important things to do during a pandemic is to contact trace, the state was sort of taken a little bit off guard. So as fast as they were looking to organize contact tracing to be able to work in counties, we knew that was going to be slow. So Elisa started doing it at I have to get Union Community
What
Care.
was there? What was
Union Community Care. I just can't even
Yeah.
say the other name because then I'm trying to get it out of my mind. So Union Community Care. So Elisa and her colleagues, they all jumped in and started doing right away for their patients. And then we, as a sort of a larger health system, thought it needed to be done from a county standpoint. And so we asked for, information real time as opposed to taking a long time, because contact tracing is most effective is as soon as you know somebody's positive that you begin to identify their contacts and then trace them. So, that really would help hold us up from a pandemic standpoint. So the way we landed was that, we from a health system went ahead and built a contact tracing department that was rather large because we did a majority of the testing. So we tested a majority, about 80% early on of the people in Lancaster County for COVID. So we had that information and we had it in real time. As soon as the test was done, we got it to case investigators that were able to find out the contacts and move that along. And then there was a bunch of other people that were being tested where then that information went to the state. And then by the time the state handed that over to their contact tracing, it took several days. So we asked for that data set from the state to say, because we know how important it is, we're willing to do this, just give us that data set. But because we don't have public health authority, they're not allowed to share that information with us. So that's one immediate example that we just saw from the pandemic. There was that certain amount of people then that we weren't able to make that happen. But fortunately, Lancaster Health Center, and we worked collaboratively, and WellSpan joined us as well with their patients that they were testing. So eventually we got it under control, but it stalled in the beginning because of that. We did not have that data and information that could be done for a basic public health function. That's one of the oldest that have been shown to work. Works effectively with TB, HIV, contact tracing is the thing to do.
And it was a life and death situation, definitely. Okay, so what were you going to say about non-COVID times?
Non-COVID times, I would say the same thing about lead. I think from a lead standpoint that we don't have access to that data. There's opportunities and a lot of discussion with the Lead Coalition and others. If we can get that type of information real time to be able to act on it and make it actionable, do education, potentially remove the child from the home, be able to do some abatement type of strategies, that would be very beneficial. We, again, if we're looking from a health system standpoint, wanting to do that, we'll be able to do that for our own patients. So we've been okay now as it relates to our own patients, but once we want other data that's outside our own patient population, that's not available.
So, and let me make this clear because we had a question about this. There is only one way to get that data. There's one way in Pennsylvania, and that is to have a public health department, a community public health department. You can hire all the people you want to look at public health, but you're not going to get the authority, which Alice mentioned. You're not going to be able to quarantine people and have that authority, and you're not going to be able to get the data from which to work to better people's health in times of emergency, in times of non-emergency, unless we have the community health department. And I think so many people have recognized that over the years, and so many more, are beginning to recognize this. One of the good effects of the pandemic, I guess you could say. Anybody else?
Can I just add one last thing to that? Right now, the city of Lancaster has a huge grant, $9.8 million for lead remediation, huge grant. And that grant is being used to, make homes within 4 census tracts in Lancaster lead safe. If we had data, because the data that we get from the State Department is aggregated, if we had our own public health department, we would be able to stratify that data and know exactly where the problems are, where the majority of the homes are. And therefore now that data can inform the writing of proposals that would get us money to make the homes safe. So there are various ways in which that data becomes helpful, but now particularly in bringing more resources into particular communities that would need them.
And by aggregated data, basically what we see when we look at the surveillance report, which is 2 years old usually, is, okay, there were this many people in Lancaster County, this many children, what were their ages, what were their race, were they poisoned by lead? That's it. We don't know where they are. We don't know how long they've lived there. There's no way we can intervene. And Dr. Phillips, I think you would probably agree that during something like the polio outbreak, if you don't know where the people are,
Right.
what are you going to do? Are you going to be able to be as efficient as possible without knowing the data?
And right now, what we've tried to implement in our borough is our zoning officer who's looking at housing is taking samples and submitting them. But that is so, it's so random.
Not only is it random, it's after the fact. It's after kids have already been poisoned. We need to be able to know so that the next family doesn't move into that house with potential lead poisoning. We need to know that.
But that's what we're trying to do in Manheim. Our zoning officer is going to test.
And that way you're not testing the child as a canary in a coal mine. You're actually testing the coal mine.
That's right.
So I think there's a couple, we need to wind down soon in about 5 minutes, but I think there's some really important issues here that we've talked about. And I did want to add one more thing about the social determinants of health that I found out from being on an NAACP committee, is that things that you never think about, especially when you're not Black or brown, but that utility bills are higher on average for people of color than people who are white. And I was so naive. I said, why is that? Well, the housing conditions, the HVAC conditions, the even in Lancaster, we mapped the city and found out that areas of lower socioeconomic health had less trees.
Mm-hmm.
They say tree line boulevard for a reason. It's usually more upscale community providing shade and protection from wind and things like that. So there are so many, I feel like there's so many issues that we need to talk about, but I want you guys to tell me what issues we haven't talked about, because I'm making a note for Kevin to hold this again, and we need to delve into some more issues.
I wanted to make a quick point to speak, to bring us back to Dr. Meyer's presentation, and it is about the cost savings of public health. So prevention on average saves a significant amount of money compared to treating disease or treating outcome. So I think as we look at broadening the tent, right, making the table bigger for those who support public health, we really need to talk about dollars and cents. So if we use what's in all of our minds, which is the pandemic as an example, we're very fortunate that our county government leadership decided to allocate $24 million to testing and contact tracing. What if those dollars had not existed? So what would we have done? And should testing and contact tracing for a county of 500,000 people cost $24 million? It's pretty expensive when you think about it. So I think it's important for us to be able to make multiple different arguments, the scientific argument, the data argument, that it's good for everyone, but also the dollars and cents argument. And to the degree that we have those different ways of being able to support public health, I think we will be able to speak to a larger and more diverse audience.
One thing I'd like to add to that, though, because it's very provocative to have this discussion and to think about it, but it does sort of, even in our discussion of social determinants of health, it does really, in my mind, bring up some of the solutions. And when we think about primary prevention, what is the new definition of primary prevention? So some might say having a strong educational system so that we educate children and everyone is educated well. Is that public health? Does that have anything to do with a public health department? Or is it what creates health? And Susan, to your point, when we think about what you learned through the committee at the NAACP, there are systemic and policy decisions that make that happen. There are housing, systemic regulations, rules, zoning that really make the systemic racism and those issues happen. And then that, it begs us to think, is that what a public health department is? Or so what is that prevention that's really going to create a healthy community, which is really look at those systemic structural policies that need to be changed in order to get to the root cause of why those bills are the way they are and why those houses are someplace that really make those bills high and all of that. I mean, that's just a whole nother problem solving from a community perspective, but it's those structural and systemic policies that really, attribute to the racism and some of the inequalities that we see in health and healthcare.
Well, I think public health is a big part of that. I don't think it's the only part, but Alice, you brought up an excellent point. I mean, if we all, including all of our leaders and as a community, had this idea that we're all in for everyone, I think we could really address a lot of these issues. I really do. And I think public health is a big piece of it, but I think you're right, Alice, that the community has to come together, like you initially said, with collaboration and really have the mindset that we want the best for everyone in our community. And I want to thank everybody for being on today. I've learned a lot. I've been inspired, and I think we're not done. We got lots of work to do and lots of things to talk about, surprisingly enough. Kevin Ressler, you're back.
I am. I've been here the whole time. I just
Yeah.
turned the screen off.
Okay.
I muted myself so I could eat snacks. This was more entertaining than most of the TV shows I watch, and it was more informative as well. And I thank everyone who came, and all of you in your homes. We can't see you, but please, little virtual round of applause for these amazing women. I got texts throughout the thing saying, oh my goodness, I'm inspired. Like, how are these women doing all these things? This is incredible. And I am just shocked that we could get you all in the room at the same time. Your schedules are a nightmare because of how busy you are. And thank you. Thank you for this conversation. Yes, Susan, this is the beginning of a series of conversations, and these individuals here and others will be invited. I want to say one thing that blew my mind a couple of years ago that I learned about. When I ran for mayor, became good friends with former Mayor Art Morris, Republican. I believe in bipartisanship. And so I reached out to him first. I said, what did you do well? And he said, I brought water to Sunnyside Peninsula. And I said, wait, what do you mean? So you were mayor from 1980 to 1990. What do you mean you brought water to Sunnyside? About 1985, the Sunnyside Peninsula in Lancaster City still did not have running water or sewer. Mid-1980s. And Art Morris said, I picked my entire political future because I said, this is unacceptable. We can't treat poor people in our community differently than we treat the rest. And so this is not a partisan issue. Anybody who wants to make it a partisan issue is being disingenuous. Health doesn't care about who you register for. COVID didn't care about who you voted for. And seatbelts don't have a concern about whether or not you are a Republican, a Democrat, a Green Party, or an independent. Health and the public health of our community is a nonpartisan and should be a bipartisan issue. And I'm glad to have a conversation or work with anybody who wants to make sure our community is healthier. Because here at the United Way, our job is to give, advocate, and volunteer, and to advocate for everyone and make sure that equity is at the forefront of how we think about how we serve the community. Every one of these women in this room think about equity and how they serve their communities. And I hope that you're engaged in conversations that help you develop, as this one was, a better and more holistic understanding of the world, the way it is and the way that it can be. And I want to say this is what popped into my head about public health. Maybe this is a definition that could be helpful. What I heard again and again was about life circumstances. And if I take myself and put myself in someone else's shoes, and I put myself in their life circumstances, will that make a healthy life easier or more difficult? that job, that location I live in? And then does public policy and investment interact with those circumstances? That to me is what I gain from the intersection of public health, and it's wide ranging. So I want to thank all these women. I want to thank all of you who attended. I want to thank your institutions as well, Penn State Hershey, Union Community Care, UPMC Lidditz, Lancaster General, and F&M for allowing you to participate in this forum. Those of you who maybe snuck out of some of your work today, thank your bosses and supervisors for letting you have this time. I deeply appreciate the work of every single person in this community to make it the best possible place it can be to live, work, and play. We hope you'll continue to tune in. We hope that you'll consider a donation to United Way, and we hope you'll consider supporting all the other initiatives that you heard today, including the doula program and Union Community Care and all of these places. Vote for Carol Phillips, vote for Dr. Catherine Schmitz, and always vote for Alice Yoder, no matter what she's up for. Thank you, everybody. Have a wonderful, wonderful day.